My guest today is Professor Paul Salkovskis. Paul, please would you mind introducing yourself?
Yes, sure. I'm Professor of Clinical Psychology at the University of Oxford. I'm also a consultant clinical psychologist and the head of the course for training in clinical psychology in Oxford Health NHS Foundation Trust.
Wonderful, Paul. And you are a world expert on obsessive compulsive disorder. I have heard you speak in a number of conferences and really impressed by what you have to say. I'd like you to tell me first about what are the kind of patients you see for obsessive compulsive disorder? How do they present to you? What are the kind of complaints they bring to you?
There's a range of different ways that obsessional problems present. The one that everybody's familiar with is people worrying about contamination and then washing their hands, sometimes to a very extreme extent using bleach and so on. So that's called washing contamination. There are also people who check, and that can be checking doors, windows, stoves, electrical things, but again taking extraordinary amounts of time over it. And there's also something called rumination, obsessional rumination, where people are bothered by thoughts and where it's all going on inside the person's head. And they might, for example, with religious obsessions, people may have an unexpected blasphemous thought that they reject, and then they try to get rid of that and they say prayers to try and cancel it out. Or they may have thoughts that they're a paedophile and so on, those kind of things. So it's broadly speaking divided into where things go into just are going on in people's heads and where people are doing things in the outside world, such as checking and washing.
So there's the obsessive ruminations and then there's the compulsive rituals, correct?
Correct.
And how does that link to intrusive thoughts, or is that different?
Well, it kind of starts with intrusive thoughts. As it turns out, what we now know is that everybody in the world pretty much gets intrusive thoughts, images, impulses and doubts, things that just pop into their head and interrupt what they're doing. So that's not OCD because everybody gets that, but for some people, they latch onto it. So that intrusion starts to be more and more troublesome. And if they think the intrusion they've got means something terrible, so for example, if you have an intrusive thought, say about harming a child, that's obviously a very frightening thing. People become very frightened and then they do things to try and stop it from happening. And the most obvious way in which that becomes counterproductive is where people have one of these thoughts and they try really hard not to think it. And if you try really hard not to think, say, about a polar bear, then you're going to think about it more, which is fine when I say it in this way. But if you're in the middle of the night and you have thoughts about harming someone you love, then that can be absolutely terrifying. And one of the things, it's obsessive compulsive disorder. The disorder bit is the massive amount of time and distress that people experience with this. And it really is torment. It's a hellish situation to be trapped by OCD.
I see actually more people with intrusive thoughts that are quite distressing. Often it stops right there, and then obviously I also see people with compulsions. But would you say that the proportion of people who have intrusive thoughts and the obsessive ruminations is far more than the individuals who develop compulsion, or in order to have obsessive compulsive disorder you need both elements?
Actually, you need both elements. It's just that when people have ruminative thoughts, where it's all going on their head, it's not as obvious the compulsion's there. I mentioned, for example, religious obsessions. People have a thought, say a thought which is unacceptable to them in religious terms. And then they say a prayer. Now, they're saying the prayer internally. That's the compulsion. And similarly, you get people doing mental arguments. So for example, they have a thought about perhaps harming their child. And then what they do is they think, no, I love them. And in their own head, the compulsions are going on. Now, interestingly, around those obsessions, there are always compulsions. The kind of hidden compulsions, the things that go in people's head, they can be worse. Now, why would that be? Well, if you think about it, if I'm worried about contamination of my hands, then I have to find a sink, wash them, soap, and so on, and that takes up a lot of time. However, if it's all going on my head, and if I can, for example, if I have a thought about harming you at this point, I can then think, no, Shania's a nice woman, I don't, and I can invisibly, it's very, yes, you hope so, don't you? but it's extremely portable. So the internal compulsions, what we call covert compulsions, they're more portable and often, so the person can be every minute of every day, in the worst case, going through obsession, compulsion, invisible to those around them.
That is so interesting, and I think often people get very confused when we talk about compulsions, and a lot of people believe that it is probably checking doors or handles or washing hands, and those are the only compulsions. And I wonder how much we miss the internal compulsions as part of these are just intrusive thoughts or ruminations. And I wonder if that needs, that needs to be explored when we speak to people or when people understand their own thought processes, would you say?
I think that's right. I think that's been missed. And the way you tell the difference between an intrusion, something that comes into your head unwanted, and a compulsion is the compulsion is something you're actively trying to do. So if, for example, and it can be almost impossible to tell if you just describe it in a superficial way. So, for example, you might have the thought, my mother will die, and that's an intrusive thought. Well, that's a terrible thought, and maybe if I think that, maybe that might have an influence on that, or it might mean I want my mother to die. So then you make yourself have the same thought, my mother might die, while in your heart, meaning you don't want it to happen. And so what the person would say is, I have the thought my mother will die, and then again I have the thought my mother will die. The difference is the second one is something the person's actively working on, and so it's something they've chosen to do as opposed to something which bursts into their consciousness like intrusive thoughts do.
Thank you for explaining it so well. What would be the cognitive reason for it? What is happening, do you think, in the brain? Of course, we have very little evidence of what happens in the brain. We have a lot of speculation about biology, chemicals, or neural networks and things like that. And then there's the cognitive model of how the brain might be perceiving things. Obviously, you're an expert with cognitive behavior therapy. How do you understand the cognitive model of obsessive compulsive disorder?
I'd start by saying I think that the brains of people with OCD are exactly the same as the brains of people who don't have OCD. The difference lies in the meaning that people give to these thoughts, which again may have its roots in things like upbringing and so on. So, for example, if I were to have the thought about harming my children, I love my children very much, but if I thought about harming them, I may just think, well, that's a funny thought. That's a weird thought. It just shows how much I love my kids because I'm worried about things happening to them. And the unlucky person who's vulnerable to OCD may have the thought that they're going to harm their child. And what it means to them is that they're dangerous, and that they should protect their children from themselves. And so what we say in psychological terms is going on is that people have an intrusive thought which they misinterpret as a sign of danger. But there's an extra element. It's not just that it's dangerous, but that they might be responsible for that harm. And that idea of responsibility, so, if I think my hands are dirty, I was out in the garden this morning, my hands are dirty, it's no big deal, I can clean them later, and it doesn't matter, we shook hands earlier, no big deal, that's fine. If I think, oh my God, my hands are contaminated, I shook hands with Shania, maybe I'll give her HIV, but maybe there's some deadly germ here. Because of that, I've got to then ask you to wash your hands, ask you, are you okay? I'm going to have to wash my hands hundreds of times in order to deal with it and so on. So it's not the intrusion, but it's the meaning, and the meaning has two components. It's dangerous, and I'm responsible for making sure that danger doesn't happen. And that's the bridge between the obsession and the compulsion. So it's the meaning that sits in the middle. If you just think, oh my God, it's dangerous, now terrible things can happen, but there's nothing I can do about it, no compulsion. If you think, I can get rid of this contamination, then you're going to wash your hands. And then you want to make completely sure, in order to be completely sure, I'm going to wash my hands a lot. And the trouble is that I'm mentally checking whether or not my hands are clean. Now, there's another thing that happens if you repeatedly check, and this is true of people with OCD and people without OCD. If you repeatedly check to make sure something's happened, that the door's closed, my hands are clean, then that actually undermines your confidence in the memory. Not 2 or 3 times, but when you get to 5 or 6, people become less and less confident. Have I done it properly? Is the door actually locked? Or am I just remembering, thinking about whether it's locked and so on? So they become they have a problem with what's called reality monitoring. Not just people with OCD, with everybody, but you and I don't check that frequently. So because we don't check, we don't get into this thing I call the checking trap. But people with OCD do, and then they want to get a feeling of absolute certainty. The more they try, the harder they try, the worse it gets. So in my view, and what the research is telling us, is that OCD is a problem of people trying too hard. So for example, they're trying too hard to get rid of thoughts. and which makes the thoughts come more. They're trying too hard to be completely certain. You can never be completely certain, but if you try really hard and if you think it's super important, then you become less certain because the checking is making you less certain, and so on. So it's really a problem where the interpretation of the intrusion makes you do things which then undermine your confidence in the outcomes because you feel responsible for them.
And how does that link to perfectionism?
Well, it's related to perfectionism. Perfectionism, yeah, in clinical terms, I mean, there's nothing wrong with perfectionism. You and I probably have a little streak of perfectionism, which manifests as a thing called persistence, that we keep doing things until we get them right. Not until they're perfect, but until they're right. But in clinical perfectionism, there's two things. People have unrelentingly high standards. So they believe that it's not just enough to do something, but you have to do it perfectly to the highest possible standard. And then the other thing is being worried about mistakes and not sure. And so it interacts with OCD, but it isn't OCD. So if you have unrelentingly high standards, then you will try harder, which will make the OCD worse. And if you have concern about mistakes, if you're constantly doubting whether or not you did it right, then that's going to feed into it. So we think that perfectionism interacts with OCD, but there's a twist to this, and it's some work that myself and other people did when we worked at the Maudsley. We looked at people with obsessive compulsive personality disorder, which is a different problem to OCD. It's not anxiety disorder.
No.
And what we did was, in the clinic we worked in at the time, we were treating people, some of whom were diagnosed as having OCPD as well, obsessive compulsive personality disorder, as well as OCD, and others who didn't. And we looked to see how that affected the outcome. And what we found was quite surprising. People who had both OCD and OCPD did better than people who just had OCD. Now that's very unusual in psychiatry, to find the co-occurrence of a personality disorder is actually making the treatment of the kind of axis 1 disorder easier. And we think we know what's happening. We think OCPD, obsessive compulsive personality disorder, is where people are perfectionistic. When they get the right treatment for their OCD, we think they try very hard to do it as they're supposed to do it, so that they're actually perfectionistic in the way they do the CBT, so that they are listening to the recordings that we make for them, they're going through the exercises we give them and so on. They're really trying very hard to do that, and that might explain why they did rather better. It's just that if you are perfectionistic, then it will make you work harder with it. I think it's complicated, is what I'm saying, really. But OCD and OCPD are not the same thing.
No.
And there are these various interesting links. I think we don't fully understand it.
I think that's
what a
what's
surprise!
online. What
a
a surprise!
Something we don't properly understand.
I understand that obsessive compulsive disorder is on a spectrum, right? You just said that we all get intrusive thoughts. The difference is that feeling of responsibility, dangerousness, and then that bridging into a compulsion and the need to do it again and again. How do we recognize the red flags? And what simple tips would you recommend if I was beginning to be in that place where I need a little bit of help? Of course, if the symptoms are severe, I would want to see someone like you. But what can I do myself? How do I recognize it? And a few tips on what can I do myself.
Okay, in terms of recognizing it, there isn't a clear line, is there, with any of these things? It's a bit like being depressed. What's severe depression? What's normal sadness? The dividing line diagnostically is spending an hour a day or more on obsessions and compulsions. So, and that's not a bad rule of thumb. If you're bombarded by thoughts and it's occurring more than an hour a day and it's distressing, then that's becoming a problem. So that, I think, is probably the best way to think about it. But also it can be less frequent if it's extremely distressing, or most importantly, if it's stopping you doing the things that you want to do. And we know, for example, that these problems are often triggered by major life changes. I mean, the obvious one in OCD is having a baby. And that's true for both mothers and fathers. So there's something called perinatal OCD, where people develop OCD around the time of having a child. And if you think about this, danger to yourself or other people, and responsibility. I mean, what could be more responsibility inducing than being handed this little bundle that you love above all else.
And what could be more precious than that bundle, right?
And under those circumstances, what can happen is that it can be difficult for mothers or fathers to hold the baby, even, because they're afraid that they're going to drop the baby or even deliberately throw it to the floor or otherwise harm it and so on. So the amount of time it's taking is important, but also how upsetting it is. And if it's stopping you doing things that are important to you, like being able to be with people you love and so on. So those are the two danger signals. Exactly how much, there isn't a clear line. If it's bothering you, then that's where you need to start to do things. And one of the things you need to do, in my view, what we do in therapy is help people discover how the world really works. Now, what do I mean by that? Well, what I mean by that is that if, for example, somebody is having a lot of intrusive thoughts, say that they might, say, hurt their child or whatever, and what they do is they try to push those thoughts away. And then the thing they need to do is do a little experiment. Try very hard for a moment or two to push those thoughts away, not think about them. And what they'll notice is they'll think about it more. And then just let the thoughts come. Just accept that that's a normal thought, that all loving parents actually have thoughts about harm coming to their children. And no parent, I think, can imagine anything worse than they themselves cause harm to their child. So it's okay. That's kind of, having that thought is okay. And if you accept it, it will diminish and go away. So in a sense, it's a matter of doing less rather than doing more. So you don't have to sort of do a lot of things to get rid of the thought. The more you try to get rid of the thought, the more it will come back. Notice that's happening. And then actually, for example, if the OCD or the intrusive thought says, don't pick the child up and give them a cuddle and enjoy it and think how lovely it is, and so on. So don't shy away from these important things because you're having normal thoughts of the kind that everybody else has.
I understand. Yes. So they say, right, if you resist, it persists. I guess that's what you're trying to say, right? So don't resist it.
You say it so
or
much
it
better than
might
I
be. I'm learning. I'm learning from you, Paul. And the other thing is what you describe as safety behaviors, because it's links to anxiety. It links to avoidance behavior is one of the safety behaviors, right? So you won't do what you worry about, and therefore that propagates the problem even more, and it becomes more entrenched in our...
So because you don't get a chance to discover what really happens. I mean, so the thought is, oh my God, unless I back away from the child, I'll harm the child. Well, you back away, you don't harm the child. You think, oh, I would have harmed the child if I hadn't backed away.
Exactly.
Or if I didn't wash my hands properly, then I would end up with some terrible disease. And you don't get a chance to discover that actually it's okay that you don't have to wash your hands that much. One of the things I'd say, people are washing their hands too much, is actually get a little bit dirty with your fingers or whatever. And because what's going to happen? Well, if you're really, 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 really unlucky, then you might get a stomach upset, for example. But having a stomach upset for a couple of days compared to having OCD for the rest of your life, no choice.
That's absolutely right. No, thank you very much for that, Paul. That was very informative. In fact, I've learned a few things as well today. If you've enjoyed today's video, please subscribe to the channel, like it, share it, tell it to all the people you know. Thank you for watching, and thank you, Paul.
Thank you for speaking to me.